have another case. Once again, I'm going to try and present just a couple of very varied cases of what we do at White. This is my first webinar, and like I say, I work with a huge team, and everybody's welcome to get in touch with us here in Portugal. If you want to come out and learn with us, we have a great education program, so feel free to get in touch with us for that. Here's a lovely lady, and in this photograph, she looks about, I'd say, 60, 65, close to 70. Well, you're mistaken. She's a woman that's had a very hard life, and she's given a lot to her children. And through the years, she's ground her teeth completely away. And this is an extreme case of loss of vertical dimension. And we did a couple of things here that I think are not many people would choose to do. And we finished this case about a year ago, and I can safely say that everything's still the way it was on the day we finished it. So let us show you how we did this case. Well, here you can see that she's missing some teeth in the third quadrant. She had a little root there. She had an old endodontic treatment that was failed with a little granular tissue here that needed to come out. And of course, this incredible loss of most of her enamel and dentine of her coronal structure. So the first thing we did was we knew that we needed support. So I hardly had any height on these teeth for my crowns to fit onto. So the first thing I did was I sent this patient to my endodontic team, and we performed the root canal on this teeth on almost, I think, on every single anterior tooth. Why would we do root canal on otherwise 100% healthy teeth? Well, the reason is because I needed to put these posts and cores into her teeth. And I think we have 1, 2, 3, 4, 5, 7, 8, 9, 10, 11, 12, 13. We have 15 posts and cores. On these premolars, we didn't do that because we believed that we had enough dental structure to hold our crowns. So while she was doing her posts and cores, and this is the day of the try-in where we made sure that the adaptation was fine, making these ones at the bottom sometimes can be a challenge. I like to use a direct impression. I don't use Durolay. We use a direct impression technique with Imprigum and a paper clip. And I'm sure that in the future I will put up a post on my expert page here on Dental XP just with the technique for taking an impression for these posts and cores. It saves time, and it works pretty well. So those of you that are curious, please write in and ask us for that. This is the panoramic X-ray after the implant placement and the posts and cores, and I'm going to show you some more close-up X-rays just now of that. I'm sorry, that wasn't it. So you can see there's quite a lot of buildup of these anterior teeth. The only way we could get the coronal height big enough for the crowns, individual crowns to fit on. I mean, there was another solution, which was to actually just bridge everything to get more mechanical structure. But I tend to find that the bigger the bridge, the bigger the problem, because patient hygiene tends to be an issue in the medium long term. So, I mean, if we can give back individual teeth, I think we should always try and do that. And of course, we place some implants here, so we could also build up these posterior teeth with crowns over implants. And the first step for doing something like this is creating a temporary or provisionalized treatment, which is in the shape of a bridge, of course, here, for quite a long period. We did this for 6 months. This is an acrylic temporary structure. And with this, we like to modulate our gingiva. We also like to make sure that the whole ATM region and all the neuromuscular situation is comfortable. And in this case, I can safely say that overnight, this patient had a huge augmentation of her quality of life, not just to mention her smile. And it's like the ATM remembers the way it used to be, and it doesn't actually take a long time to re-educate a healthy, an ATM. So if you have a huge vertical dimension loss and you just recuperate that overnight, It's like the ATM remembers, and it almost says thank you. So here we have how we did this. So we rebuilt everything. We put the crowns also on the implants at the back. You can see that there. And we raised a substantial height on these teeth. And after we were very safe with the fact that she was comfortable with this, it became time then, you can have an inclusional view of this, it became time then to place the ceramic crowns. So we like to use Improgam. Here are some of our crowns. And a lot of you might be thinking that it's crazy to use full ceramic crowns on a case that is so blatantly of that of a bruxer or somebody that suffers from serious grinding. Well, also studies show that this ceramic is a lot stronger than the natural enamel, almost 6 to 7 times stronger than natural enamel. So we felt safe to do that. And here is the lab work, and this is the day of cementation. You can see that we used a little bit of gingival ceramic there because she had some bone loss there, and instead of putting her under surgery, we like to just do that with a little bit of ceramic gingiva, and plus she has quite a low smile line, so that was never going to be a big issue. And here you have good endo work from my team. The post and core is placed in place, respecting a long endodontic area to make sure that we're not keeping that too short there. And you can see the perfect adaptation of these crowns, which is going to give longevity and keep out the bacteria. And once again, this is a full mouth rehabilitation. And we did this all at once. We didn't do this gradually. So this was done, everything was done simultaneously. And this is 1 week after cementation. We knew that the height was good because her temporary crowns had told us she was comfortable. She was chewing fine, and she actually had over time we were checking her occlusion with paper to see if she was having any grind areas or areas of higher abrasion. And this is much easier to see on the acrylic than it is on ceramic. So she kind of stopped grinding. It was almost as if her vertical dimension was making her grind more. So her loss of vertical dimension was making her grind more. And now, since she's recovered that, she's in a different phase of her life. A lot of us tend to look at a mouth like this and think that our patient is actively a grinder. This patient, 65, I believe that this problem might have started when she was 15, 16, 17 years old. You know, she's a grown woman now. She's had kids. She's a granny. Probably that stress is subdued and is not so active anymore. And of course, if you spend time with your clients and you listen to them and you talk to them, you can actually find that they're in a lot better place today. And it's great to give them back what they've lost over so many years. And you can see here before and after smile, and how you've actually just look how longer her face is on the left. You know, she looks 20 years younger. And I don't think there are many cosmetic procedures in the world that can do this other than a complete cosmetic rehabilitation. Now, I'm going to talk about 2 cases which involve orthodontics and aesthetics. So we've covered some endo cases, we've covered some bonding, some full mouth implants, a bit of surgery. I'd also like to talk to you about the importance of orthodontics prior to these big rehabilitation cases. All these cases are won, not on the last day, but they're won on the first day. They're won on the day when you actually talk to your patients and you explain to them what you want to do. Planning is everything. And many patients want speedy solution. They want fast solution. But over speed, they want predictability and they want predictable results. And very few surgical or very complicated surgical procedures are 100% predictable, no matter how good you are. Ortho has an amazing capacity to create a very predictable volume of bone and gum if you plan as well. And I'd like to offer you an opportunity then to see how we do this in our clinic. So this is the case of a patient who came in a couple of years ago, and she had probably one of the most complicated aesthetic cases a dentist can have in his office, and that is the total loss of bone in the interdentary space between two central incisors. I mean, this woman is a 32-year-old woman. She's an active woman. And what actually happened was she went in for a bit of orthodontics. She had wanted to do some bonding on this tooth here. And the dentist had said, well, that she needed to do a frenectomy because she had her frenum quite low. Now, most of you know that if you have the need for a frenectomy, then you have excess gum in between your two front teeth. So to go from having excess to a defect like this is quite a serious problem. So what had happened was, what had happened was she was looking for an orthodontic treatment, and what they had done here, you're going to see just now, was that actually then mesialized these two teeth to close the gap and fused them together with brackets. And they used excessive forces on an unfavorable biotype, and they had done a laser frenectomy that had just eaten away the bone. So she had an osteomyelitis on her bone, so she had an active infection that was exposed bone. So this is exposed bone, and almost no gingiva. So what to do? How do you explain this to a patient who has gone in for an otherwise simple treatment to come out with probably the most complicated case to treat? These are very highly complex cases in the sense that your patients are emotionally quite damaged, and it takes a lot of conversation and a lot of science to win them over. And there's a lot of evidence out there that shows that what we did works, and it wasn't a shortcut, it was the long way. So this is how she came in. And for those of you watching this around the world, of course there are a lot of you that teach me, and I'm always learning. And this is it's not about those that know more and those that know less. I mean, I'm always learning. I spend a lot of time myself on Dental XP learning from my peers, and I just hope that those of you out there that do implants and that do orthodontic treatment would never think of placing an implant or doing orthodontic treatment when you still had leftover roots in the mouth and a really bad oral hygiene. I personally find this appalling, and of course this is not representative of any particular country. This happens all over, and I just think that we should really be careful and keep our priorities straight, which is health first. That means a clean, healthy mouth before you go into any complex cases like orthodontics or implant surgery. So please keep that in mind. So we removed the braces, we removed the brackets, we raised the full flap to get a good glimpse of what we had here. And as you can see, a very, very large bony defect where once there was bone and gum. So what we did was we packed this, we cleaned everything up, we scraped everything out, we cleaned that with saline, and this is BioOS that we use here. So it's an allograft particulated bone that we use here, and we cover that with a BioGuide, which is a collagen membrane, it's a resorbable membrane, and here we have a microtack, which it keeps this in place, and we suture that back in the mouth. This is immediately after the placement of our graft, all right, and you can see inside the canal. This is on the day of the surgery. What I did was I just opened the tooth, I took out the nerve, and we placed some calcium hydroxide in there so she wouldn't have any post-op sensitivity on these teeth. So an endodontic treatment always had to be done. And then we sutured everything into place, and we placed an immediate provisional bridge. So I don't know if I told you, this patient came from quite far away, and we were in no place to leave her, to go home without any teeth. And making very sure that there was no excess composite against our suture region. Now, we had that patient come back after 8 days, and we can see that the healing has happened. We've got a little bit of exposition of the biowash coming out there, all right? But the healing's kind of okay. And this is where we decided what we were going to do. Now, initially, my plan was to always basically mesialize the roots of these teeth, bring the roots of these teeth together to kind of condense that bone so the interdentary distance would be smaller, because we know that the smaller that space is, the more probability of creating a papilla. If you go to Dr. Salama's studies and all his books and Dr. Garber's studies and all in there that they published over the years, you will find that this evidence. And I was then going to think of extruding these teeth orthodontically so that the bone and the gingiva and the soft tissue would follow. But my initial plan was to always extract these two central incisors and replace them with implants. All right, but once again, you have to keep all your options open. So here we have the endodontic treatment finalized, and you can see how divergent that these roots are, and that this space in between the two teeth was way too large to ever think of getting a papilla. So what we needed to do was to bring those two roots together and then slowly pull them down. So here we have the placement of the bracket, a very simple procedure. The wire was activated to slowly make sure that we would bring it down on a level of maybe 0.5 millimeter a month. Now, it's very complicated. You have to make sure that every time that these central incisors start touching the bottom teeth, the patient has to come in and you have to start grinding them down, because otherwise they're not going to descend correctly. So you have to always control the occlusion during these procedures. And here we have the orthodontic procedure at 3 months. We changed these for acrylic crowns. And you can start seeing that the healing process is still not done. But look, the roots are starting to straighten out. The bone, which is biowash bone, we know that studies show that it takes about 6 months for the osteoinduction and osteoconduction to take place, for this to be transformed into natural bone. But look at this. It's quite interesting. All right? So let's bring this forward. This was after the 8 months of orthodontic treatment. Patient came in. We actually had to do some gingival contouring. We used an electrophysiology for that. And we placed a set of laboratory provisionals. This is a set of, they were all fused together. Now, one of the most amazing findings of this is that the two central incisors were not mobile. After such an extended orthodontic treatment, there was no mobility on the central incisors. The probing depth was almost null. So we made the decision to actually keep these central incisors. And the thing that we did was we fused the two crowns together just for mechanical stability. So here we have, after 1 year of orthodontic treatment. Look how these teeth are closer together. Now, and look how much more bone we've had. We started with the bone up here. The bone is now down here. So not 100% perfect, but it's a lot better than it was. And this is on the day of making the taking impressions of the full ceramic crown. We extended the treatment to the canines for cosmetic reasons. Here are our Empress crowns. And this is the day of cementation of the definitive crown. And this is the 1 week follow-up. Remember me telling you, we fused these two together. We kept the contact point. The reason why I kept it fused, because I wanted this contact point as low as possible, because you can see the classic study of the 5 millimeters from the contact point to the crestal bone. If you keep under 5 millimeters, you will always have a papilla. I don't need a 12-year follow-up to show me something that has been in the evidence since 1996, I think. So we know that if that contact point is 5 millimeters, if the occlusion is good, if the hygiene is good, and we make sure this patient comes in at least 4 times a year, that papilla will always stay there. And I think it's very important for us to look at the final result and remember how devastatingly big this hole was in the aesthetic area, how all now the gingiva is in a good place. So once again, a very simple team approach where we had endo, ortho, perio, and the implants were actually not necessary, and then finalized with a good prosthodontic rehabilitation. And of course, during this whole procedure, our dental hygienists make sure that this patient stays highly motivated. So here we have the end case and the final smile. We were very lucky that she actually had a low lip line here. So regardless of how bad our treatment had ended up, you know, we could have got away with murder, but we didn't want to. We actually wanted her to be able to lift up her lip and see a good result, because at the end of the day, she was only 32, and she just started out wanting to straighten her teeth and had to go through hell for a year, because these things aren't easy, and of course they're not cheap. So I think that this is quite a good case to show a full team approach. And don't be scared if you have cases like this. And if you don't have a big team, then at least know how to refer to the right person and make sure that everybody's communicating. These cases are won through communication and planning. Nothing else. The science is out there. This is not complicated. It's just a question of organization, treatment planning, good communication between your team and your patient. And you'll win all your patients. And this woman, for the rest of her life, will thank everybody on my team for having done what we did for her. And I'm sure if you do the same, you will have the same in your business, in your practice. And I'm going to finalize this presentation with another ortho aesthetic case, very similar to the previous one. Here we have her initial photograph, and this is a case of a patient. She's a 32-year-old woman that has been with the periodontologist, not on my team, but was with the periodontologist, who's done a great job at eliminating her probing depth and her succular infections, and she now had hygiene. But what she had was a very large aesthetic case. So she wasn't happy with her smile. So she had health, but she did not have aesthetics. So we had to sit down with her and do some good treatment planning and figure out what to do here. Now, I'm sure that a lot of you periodontists out there will say, well, we could do some extraction here, some tissue grafting, some bone grafting. Yes, great results. There's a lot of studies out there. There's some amazing webinars and some amazing articles on Dental XP regarding these procedures. But we wanted a different approach. We wanted something that could probably give us a little bit more guarantees, which was orthodontic extrusion. Now, as you can see in this x-ray, we had quite a bit of the tooth still left in the root and quite a large loss of bone height. Please forgive this x-ray, but it's the only one we could find. And you can see, after correct endodontic treatment, she had a post and core placed, and a very simple orthodontic, this is the orthodontic brackets placed, and just a bit of management there. And we started pulling this tooth down at about 0.2, 0.4 millimeters a month, always checking to make sure that every time it hit the bottom tooth, we would grind it off another 0.5 millimeter. These extrusions happen very fast, but you have to give time for the bone and the soft tissue to reorganize itself and solidify and consolidate. So you can never really speed these things up. But you can notice, look at the level of the bone there, and look at it here. We've already got new bone formation at a higher level. Now, as Dr. Garber says, and I'm sure a lot of you know this, issue is the issue, but bone sets the tone. All right, this is a great rule for people doing these things, and you can manipulate the bone surgically, but nothing easier and more simple than actually using orthodontics to help you with this. And Dr. Salama has some great studies in his book, and done many years ago on this, and that's actually where I get this from. So after the ensuing 8 months, we brought this tooth down quite a bit, and you can see that we decided we've done a lot of cutting, so this used to be here. And we've got a canine here that with a bit of gingival contouring, if we bring that up here, we can manage this a lot better. Now look at those soft tissues there. This is all new. That was way up there. So here, on the day that we finished, we took that tooth out because it wasn't viable mechanically. And look at where that bone is right now. That bone is at the same level as the adjacent teeth. That's exactly where we want it to be. And in the literature, you have to go, you can study all the charts that have been out there. This is what we want. All right? And we placed our implant immediately. All right? We used the new laser lock implant, and this has a very special series of micro grooves around the neck, so the soft tissue also adheres to it. But simultaneous to this placement, we also did a bit of bone grafting to push the gingiva out. So we do this while we're grafting. So you can see that we're actually augmenting it there. We just, with a very thin periotome, we lift the periosteum up and put that bone under there, and we feel that this helps. So here we have the privatization of these teeth, and we waited a full 6 months to make sure all that soft tissue was in place. Then we do our preps, very conservative preps. I don't use retraction cord. I haven't used retraction cord in I'd say over 6-7 years. Only in very specific cases do we use a retraction cord. We do very minimalistic preps here, and we make sure to not harm the soft tissue ever. And here we have the lab sends us the teeth back, and this is on the day of cementation. We like to do all our try-ins. We like to make sure that radiographically that our teeth, that adaptation is good, because we know that that connection there is going to give us longevity. And you can see this implant is completely integrated, no bone loss there, and the crowns are very well adapted. We cement this with Relay X cement, and this is 1 week after cementation. I can safely say that this was about a year ago, that things are the same today as they were about a year ago. So if you have questions, I can send you those photographs too. But I think it's quite safe to say that this is quite an impressive gain of soft tissue, not using surgery for all effects. So I don't consider that implant a complicated surgery. So there you go. Orthodontics helping to create a better emergency profile of our teeth. So here we have the end before case. And this patient is extremely happy. And once again, we never would have done that had we just limited ourselves to that lateral incisor. So a complete overview of health, function, and aesthetics really makes your patient happy. And basically the rules to this philosophy of no pop smiles are a good team and commitment to the plan, good communication, and if you've got the right person, the right colleague doing the right treatment, and you don't try and do things that you're not 100% comfortable with, you'll be fine. So I'd like to thank you for your time. And once again, I'd like to thank Dental XP for this amazing technology that allows people from around the world to talk about what they do. Please feel free to get in touch with Dental XP and ask us all the questions you want. We'll try and answer everybody. And if you want to get in touch with us as well at White, please feel free to do so. So thank you very much, and goodbye.